Okay, thanks for coming to the Center for Global Development today. I'm Amanda Glassman. We've been working for a long time to understand efficiency and performance of global health funders and their counterparts in country. And we've been working for the past year on procurement and supply chain and really feel that there are so many opportunities for savings that we could realize as part of efficiencies that could in turn be plowed back into saving lives. And I think one great interest is around private sector innovations to improve the distribution of health products. I mean, on the one hand, about half of total spending in low and middle income countries happens out of pocket directly by patients, consumers. And while public money is on the rise, access to quality assured medicines through the private sector has to be a huge priority in the future. And on the other hand, public sector procurement and distribution of medicines can be notoriously inefficient. And so the question is, when we compare it to best performers, both on the public side and also in the private sector. So it's good news to see that several sub-Saharan African countries, notably in Kenya and Ghana, there's a huge group of new not-for-profit companies that are working to reduce these inefficiencies and add value to the market. I guess the question for us all is, are these profitable? Are they reaching the so-called bottom billion? How well are they doing? Who is investing? And are we really deploying the tools of development finance to invest in some of these interesting startups? So we're really excited and pleased to welcome Mara Hansen-Staples and Cynthia Eldridge from Impact for Health that will discuss their very interesting landscaping work of these new companies, of these startups, about 30 companies that are offering services to improve the supply to providers and to consumers directly. So I'm really excited that they've come and that we have the opportunity to talk about it here. So we'll have them come up, give their talk. I'll ask some unfortunates that have volunteered to make some comments first, and then we'll go to the audience and have a round of discussion. So go ahead, please, thanks.
Thanks. So afternoon, everyone. I'll have to see how this works. Am I controlled? We have a slide deck. Great. So thanks for having us here this afternoon. We're really looking forward to presenting this landscaping to you. We wanted to thank HSCL Consult in Nigeria, who helped with some of the on-the-ground research, as well as Tracy Brett in South Africa. And want to thank also the Gates Foundation, who supported this and was a real thought leader in the development of this work. So the goal of the project really was to look at emerging trends in health product distribution and the potential impact for global health programs. And we focused on the movement of we focus on the movement of products from the port of entry in the country to the consumers. And we did not focus on cold chain innovations or medical products, medical devices. Sorry, we had some diagnostics, but we excluded devices for the most part. And that meant with this focus that we had to avoid some very tantalizing, this is a big circle. Anyways, I'll learn. Some of the more tantalizing innovations that are happening upstream in terms of manufacturing and in terms of procurement, as well as downstream innovations that many of us are familiar with in terms of what social marketing is doing or social franchising. So as Amanda mentioned, we surfaced about 58 companies and focused in on about 30 of them. And for those 30, we went back for second round interviews with them to get sort of the nuance and the depth of understanding about how their financing was working, how the innovations were working. And we focused in Kenya, Ghana, and Nigeria at the request of the foundation and did a very light touch work in South Africa. A couple of other companies were pulled in outside of that geographic scope that we'll point out later. And then just to add that these findings of the work that we did it was only about two or 3 months that we did this work, were shaped by interviews with key informants from academia, from pharma industry, from investors, and other key stakeholders. And so with that context and background to these findings, I'll pass it over to Mara.
Awesome.
The dot's large.
Okay, thanks. So we wanted to start here with just a description of the challenges these innovators are facing, which you guys probably know well. And what we have here is a diagram of, an illustrative diagram of health product distribution with the private sector in dark blue, the public sector in light blue, and the NGO sector in gray here. And the arrows that go between these boxes represent how products flow in some of the markets we care about. So as you can see from this diagram, and you know well from experience, these distribution pathways are very complex. There's a lot of layers, and these layers can result in challenges related to the quality of drugs. It can result in increasing pricing, problems with availability, and problems, of course, with visibility into where those products are flowing. So here's an example of emergency contraception and the flow of EC through an illustrative supply chain. And we zoom in here in dark blue, the private sector supply chain, and then in light gray, the social marketing supply chain. And the arrows here in yellow represent how the product flows, all the way from the manufacturer down to consumers. And the red arrows represent where we have visibility into that product flow. And so you can see from here that we lose visibility into where products are flowing and have no visibility into who those products are going to from about this level downward. And the pathway of the product movement is quite complex. And with respect to EC, this multi-layered complex pathway results in a lot of markups. So what the price consumers are paying is generally about 10 times higher than the first line buyer price, which is actually about 50 times higher than the ex-factory price. So one of the major motivating questions for this work was, whether or not innovations in product distribution provide us an asset-light opportunity to invest in kind of improving basic care at scale. So traditionally, as Cynthia's mentioned, we've focused a lot on innovations at the retail level to invest in sort of retail pharmacy chains or social franchising to improve those markets for provision in a really consolidated way. The question we're asking here is, can you step above that retail level into distribution, technology-enabled distribution, and improve things across the board? And I would say the answer isn't yet clear. We don't know, but we were interested to find to be surprised by some of the findings that may point towards opportunities. And so we'll walk through these in more depth, but some of our ingoing hypotheses are listed along the left-hand side, and those included the thinking that companies are decreasing markups along the supply chain. These innovators are, and we found generally that's true. We went in with the idea that these companies are generating new opportunities for visibility. We found that's largely true. In addition to product visibility, they're generating visibility into consumers directly. We thought companies are probably serving high-end private sector providers. We found that to be false. Actually, the breadth of providers they're serving is larger than we anticipated. We thought these innovators are probably serving wealthier people. We found that to be true, but also increasingly servicing insurers. And then we thought, these companies are probably operating mostly in urban areas in these countries, and we found that to be true, but we did find some examples of hybrid blends that are moving into more rural contexts. So this is just a graphic to give you a sense as to where the companies are operating, and you can see we found innovators across all of our target geographies, and then as Cynthia mentioned, pulled in some other companies that are operating in places like Southeast Asia. Large caveat to say that I think a lot of innovation in this space is happening in Southeast Asia, in India, and in Asia, and definitely a more holistic scan to understand global innovations would be useful. We found 3 groupings of companies if you look at them by age of company and by scale. And in the upper left-hand, the upper corner here, okay, I'm not going to try to use the circle. The upper corner here, we have our largest companies, which are mass consumer loyalty and authentication companies, with the exception of mClinica. In the middle here, we have are what we call our direct-to-consumer pioneers, like living goods and healthy entrepreneurs. And these are originally grant financed, but are now moving towards different financing models in the future. And then in the bottom corner here, we have the bulk of the companies, which are very new, very small, largely self-financed innovators. So now just some key findings before we dive into kind of the specific analyses. As I mentioned, the companies are seeing high markups that exist along these private supply chains as their opportunity to disrupt, which is really exciting. So not only are they trying to offer lower prices, but they're also trying to reduce the transaction costs required to get product. And finally, they're trying to reduce variability in pricing, which can be really hard for both providers and consumers. So some illustrative examples of the way companies are reducing those prices are provided here. And in general, as you guys know well, prices on the market are highly variable. So when companies are citing reductions they're providing, they're talking about, they're able to offer up to 30% lower prices than what are the prices that are regularly available to their customers. What's interesting, of course, is that these price reductions are super interesting for consumers. They're also really interesting for pooled purchasers like insurers. So you're starting to see those relationships develop. The second kind of big key message, as I mentioned, is that across the board, these companies are offering sort of unprecedented visibility into product movement to providers like hospitals, clinics, pharmacies, and even drug shops, as well as visibility into consumer behavior. So you can see some of the examples as to the ways they're doing this, and we'll talk more about this in the coming slides. But, in OECD countries or in North America, organizations like IQVIA have, of course, built multi-billion-dollar businesses kind of aggregating, analyzing, and selling data on prescribing practices back to manufacturers. And it's no surprise that these companies see the sale of their data as a potential future revenue stream. But I think one of the open questions is, in newly digitizing markets, can some of these countries develop policies and regulations and partnerships to ensure that those data more regularly inform health system decision-making? So now I'll pass it back over to Cynthia to talk about findings further.
Yeah, so this next part of what we wanted to show to you is part of our findings and how we analyzed and looked at the companies to come to some of those conclusions that we just put at the front. So in looking at these innovations, we developed a framework which helped us understand the landscape. Hopefully it helps you as well. And it's what we observed is that the companies and their innovations fall into two main categories, either those that are consumer-facing and those that are sort of provider, in this case, like the retail pharmacy-facing. Those that are consumer-facing, the services that they're offering, across this framework actually, the services that they're offering are really developed to address some of the challenges in the market that Mara referred to earlier when she walked you through the example of EC. So what we found companies that were focused in on consumer information, and that in this case meant those that are offering consumers information on the location of the commodity or the price of the commodity or the authenticity of that commodity. And we had those companies that were focused on that direct-to-consumer distribution, so finding ways to control the product right down to the dispensation with the consumer. In the more provider-facing innovations, what we found were those companies that were innovating in the stock financing and ownership, so finding ways to provide credit or pay-as-you-dispense financing or even brokering some of the payments. Those innovations tend to unlock activity in the other innovations, let's just say that. We found those groups that are focused on inventory management and offering inventory management actually as a service to these providers. We found those groups that were focused on creating a digital marketplace and offering fulfillment within that. And so they are creating easy ways to connect providers and suppliers in sort of an unprecedented way. And the last area is the group purchasing. So those groups that are focused on finding ways to aggregate orders with disparate providers, ones that haven't participated in this before, and negotiating volume-based discounts for them, and critically offering a predictability and reliability in the pricing of those products. So using those categories that you can see here, we looked across all of the companies, the 30 companies that we mentioned to you. And the one thing that we want to highlight to you is that the majority of companies, if you look at the dark green boxes, are actually offering, they're not one-trick ponies. So they're offering services in many of these categories in complements. And what you see in the light green squares is that they are, they're innovating and they're pivoting. And it's very hard to tell what's going to win in these markets. They're testing things out. They're trying to figure out how to become sustainable. The next layer of analysis that we did was to look across those service areas and those companies to see what kind of impact they were having. And we looked at, we evaluated them basically using the blue squares. You'll see it in the, oh yeah, good. We use these blue squares, so you'll see anything with dark color is higher impact. And we looked across these 7 areas of impact. So we looked at availability, quality, cost, and geographic access to see how these different innovations were impacting. And these were driven mostly by the areas that the foundation was interested in, but I hope that there is other global health partners are interested in as well. We also looked at, to provide some context on those ratings, the scale of these innovations, which is critical because, as Mara pointed out early, they're young and at small scale. So just to give you a context for those impact analyses. So this first set of analysis, those companies that had offered consumer-facing innovations. And what is important, the key takeaway for you all on this slide is that these companies are creating valuable digital relationships with their consumers and allowing a tracking of the product through the system. On the left-hand side, you see companies that are offering sort of commodity locator companies, and there are actually quite a few of these in the market. There are a lot of these in the market. But what you see is that they are they're pivoting quickly, and they're trying to find ways to get scale and to become sustainable. And so, because the commodity locator part is difficult. So what I want to focus your attention on is those companies on the right-hand side that are the mass authentication companies. So these are companies, as you see from the triangles, are ones that are operating at greater scale. And they are companies that are offering, that were started up about 10 years ago to stop the counterfeit drugs. And they have, most of them have sort of a variation of some smart label that you can track the product through the system, and then it's verified by the client at the end. The key thing for this group to understand is that they are operating at a scale that is unlike all the rest of these innovations. They have collectively authenticated over 5 billion transactions for over 100 million users. So they've got scale going. And the salient thing for this group is that they've embedded this technology in marketing campaigns. So they've paired this with campaigns to win a phone, I don't know, win some money or whatnot, encouraging consumers, whether or not they're worried about the quality of their medicine, to verify the medicine. So you've got that direct consumer connection for when they've bought and used the drug, which is unusual. This next set of companies are offering the direct-to-consumer distribution. And what I want to highlight to you here is that the usual suspects, so those that are donor financed for the most part, not surprisingly, hit a lot of the impact marks in terms of quality, in terms of geographic access. But what was surprising for us to note was those that are more commercial and don't have that donor financing in their background, so the MyDawa, Dawa Plus, Go Pharma, are finding ways as well to hit all those same impact marks and to go rural as well. It's in contrast to our hypothesis that Mara presented at the beginning, what we find with these D2C models is, yes, they are going and serving urban clients for sort of who are very focused on convenience and wellness products, but they are also finding ways to work and deliver to rural clients who are interested in sort of high cost, hard to source medications for chronic diseases. So they've got this actually a dual market, which is interesting to see. To add to that is that when they're going into these rural markets, they're not necessarily constrained to a strict D2C model. So they're finding hybrid ways to do this. My Dawa, Dawa Plus, and Go Pharma are actually leveraging existing rural providers, the assets they have, the customers they had, and they're adding on the quality products and they're adding on the reduction in costs. So the last group of companies in the analysis are those that offer the provider-facing innovations. So that was the group purchasing, the stock management, stock financing. And in general, what you can see, if you focus in on the blue squares here, is that they're all working really hard, of course, to assure the availability of the products. And they're focused on reducing the cost to the providers. There's a mixed effort in terms of the quality of the product, which is interesting. And through the digital platforms that they're leveraging to do this work, they are, as we saw in the earlier with the other companies, providing this novel visibility into the flow of the products. And down to hospitals, down to clinics, but even down to second-tier drug shops into lower level in the system. And it's those data of the product movement that is of interest to these third-party payers and to these insurers. And I think the last point we wanted to highlight to you is that again, with these provider-facing companies, is that we saw a surprising number of them finding ways to increase their rural reach and their rural access. So I'll pass it back to Mara to talk about some of the recommendations.
Yeah, so thanks, Cynthia. If we zoom out and say, so, what are the potential opportunities for the global health community? We came up with kind of 4 buckets of opportunities that we'll talk through today. And I'll be interested in your thoughts as well on what the other opportunities might be. First, I think there's a real obvious and exciting opportunity here to leverage the consumer relationships that have been generated by these marketing and authentication companies to understand where products we care about are moving, to promote adherence, and then even use those digital relationships to do targeted subsidy transfer for products. So a great example of this is mPedigree in the center. So 90% of the packets of emergency contraceptive that they place their label on are verified by users. Users are very interested in using an authentic product for that moment in time. And I think that digital relationship can give us a pretty immediate picture as to where EC are moving in some of the markets we care about. You can use that digital relationship to promote proper use of the product. You can counsel women through that digital relationship about side effects. And then interestingly, you could maybe push a digital a coupon to that woman if she's interested in using a longer acting and more effective contraceptive method. Another example of this is PharmaSecure. They're a very similar company. They've had great success in using that digital relationship with TB drugs to nudge adherence. So this is a really exciting opportunity. As Cynthia mentioned, these companies are at scale. One of these companies is profitable already, and they're working. They all started with a focus on medicines, but they authenticate and do marketing for a bunch of industries now across the continent and in Asia. The next set of opportunities is around direct-to-consumer. What do we do with these emerging direct-to-consumer companies? They're very exciting. But I think one of the things we need to understand is the unit economics of these direct-to-consumer solutions and really dig into when and where it makes sense to engage them as they scale. And then secondly, I think these direct-to-consumer companies obviously also have digital relationships with their consumers, so the same opportunities that we described in those kind of information companies would apply here. A really exciting company in this category is My Dawa, which is based in Kenya, and they are a generics manufacturer. that controls supply from the point of manufacturing in India all the way down to delivery to the consumer. And they do delivery in a couple different ways. In rural areas, as Cynthia was saying, they'll deliver to a provider, give that, a pharmacist, and give that pharmacist a cut of the sale of that medication. In urban areas, they'll deliver to offices and homes. They have a really strong quality assurance system for their products. You can track the movement of that product all the way down. And that's paired with a telepharmacy dispensation center. So every product that's ordered through their system, a pharmacist speaks to the customer that ordered it on the phone. And then the third piece of quality assurance is that the delivery is made by a pharm tech. So at that point of handing the product off to the person, somebody who's trained in dispensation handles that and can provide follow-up counseling and answer questions. So it's really exciting. The control of the supply chain end-to-end allows them to cut costs. So they estimate they're able to cut about 40% of the costs in moving product out by maintaining control, and they pass along about 15 to 20% of those cost savings onto the consumer. So you're talking about a model that is giving you a pretty wraparound service at a price that's slightly lower than what's available on the market today. Let's see. So I think there's a couple opportunities that a system like MyDAWA presents to us. You could just leverage what they have today and use it as a distribution system for some of the products we care about in global health. I think in the urban areas where they're operating, I think you could look at how to leverage that hybrid model they're using in rural areas as a distribution channel for the products we care about that are not episodic, that require regular delivery, like HIV medications, oral contraception, DMPA, IM, and SC, TB medications, potentially. And then finally, I think this digital relationship you have with these consumers also might allow you to target discounted financing directly to people we care about. So, you could do some geographic targeting and say anyone who orders, contraception from an area in Eastleigh, we're going to go ahead and assume they're poor and offer them a discount on that product that's funded through, public financing. Okay, we'll head on to the next one. The next category is really around the types of innovators that are doing provider-facing services. And I think there's an opportunity here to leverage these innovative supply models for wider distribution of the products we care about in global health, which would offer us increased visibility into that product movement. And there's potentially an opportunity for us to continue to nudge them when it makes sense for their business economics to move into more rural areas and serve lower level providers where poorer people are accessing care in some cases. So, the two companies I'll highlight in this category first is Drugstock, which is a Nigerian company that's serving the largest number of providers of any company we found in this category. They're serving about 1,500 hospitals, clinics, retail pharmacies, and experimentation with second-tier drug shops. So they're doing pooled purchasing, and they also have a digital marketplace that connects pooled purchasing for hospitals, and they have a digital marketplace that connects other types of providers to suppliers and facilitates fulfillment. So you could, folks in the global health community could leverage that network and test out distribution through that. I also think, in Nigeria, most people are seeking care for basic conditions at lower level drug shops called PPMVs. So is there a role for the global health community to help Drugstock experiment in a business model that might make sense to expand to providing products to that level? The next company in this list is Numi, which is here in the center, and they're in beta mode in Kenya, and they're currently working with community pharmacies that are located on the outskirts of major urban areas. And they're a set of engineers from Silicon Valley who've decided that the challenge in supply is one of customer service and cost. And so they offer their community pharmacies basically like a white glove supplier service and pass along the medications they provide, which are 250 of the fastest moving products, at no cost. So, no markup, to try to gain market share. So they're taking an approach that's data-driven, sort of technology-enabled, and they believe there's a huge market to supply community pharmacies with really high-quality supplier services, quality-assured drugs, at very low margins, but at high volume. So I think that's an interesting model to watch and potentially support as they try to move beyond what they call the donut of community pharmacies right outside the central business districts in a lot of major cities out a bit further. Is there a way that they also could serve drug shops in a slightly broader set of providers? Okay, the fourth area of interest is really an opportunity for the global health community to think about how do we ensure that this novel visibility into product movement and consumer behavior both informs health systems and while protecting consumer privacy and while protecting consumers' data. So I think the first question is really how can we use the data generated through these innovations to benefit public health decision making? Rather than it just becoming an asset that's used for better forecasting by the pharmaceutical industry, which is, anyway. So I think the question is really how can we support governments and major health donors to construct regulation and policies and partnerships to ensure data are regularly feeding into forecasting, but also supply chain management, health financing, target setting, demand generation, adherence strategies, et cetera? How do these data become public goods? And then the second question is, as these technologies scale, how can we ensure that consumer data is protected and is private? And I think, it's our experience that there's a lot of excitement around innovations, data-driven innovations in global health today, but that a lot of folks in this space, it feels to me like they're insufficiently considering how to protect consumer data as well as personal health information in contexts where civil rights can be quite tenuously enshrined. So I think there's a real opportunity to think about how do we support countries and how do we ourselves invest in these innovations in a way that serves both the system and the consumer over the long term. So that's all. And maybe I'll pass it over to Amanda.
Thank you.
Yeah.
I'll invite you up to the stage now. Thanks. Which company is this? This is Drug Stock.
Drug stock, yeah.
Okay. Well, I think where's Jesse? Here? Yes? Do we have Prashant? No? Okay. So we will be taking some inquiries from the phone or Twitter. So if you do have questions and you're online, can you please tweet them with the CGD Talks hashtag? So we'll turn to the audience, so prepare your questions and comments, but I'll first ask you one question that immediately comes up, which is you mentioned one of the companies on one slide was profitable. Mm-hmm. Can you say something about the profitability of these companies? Many of them early startups. That will link to another question I have about could there be a role for development finance here or these private sector windows? USAID just announced a new private sector strategy. So what do we know about profitability at this stage?
Yeah. So the one company that's profitable, which I can't remember which of the three it is, but is in that space of, mass authentication. Mm-hmm. They've been operating for 10 years. The rest of the companies are really, really young. So they're not yet profitable. They're mm-hmm. early stage startups, largely self-financed. Mm-hmm. Yeah.
And how many of them started with a philanthropic donation versus a VC? Do you have any sense about that?
So most of them don't have VC financing. There are literally people in this space who are financing this themselves. They believe in their company idea. Some of them come from more of a development background or have worked with various development initiatives in the region. But there's a surprising number of them who are self-financing, and there are several companies who are explicitly, they believe in this enough that they don't want outside investment, which I actually think is quite exciting. That's not all of them, but there are a few. The exception is, of course, healthy entrepreneurs and living goods, which have always had grant financing.
Mm-hmm. Yeah. Okay. Interesting. And so, when we think about the OPICs of the world or the IFCs of the world, that they would be looking for this kind of information before making investments, and that's obviously very intimately interlinked with the scale of these initiatives. Do you have any sense? Do you see any sort of constraints with the existing health system and its organization, the way distribution is currently set up into the private sector or via the public sector, that would inhibit the growth of these young and interesting companies? I mean, if they show they are more efficient than, I guess you would be selling it to each each insurer, each hospital. I mean, what do you see as barriers to their further growth and development?
The ones that I spoke to, it's still the access to capital so that they could grow. Do you know what I mean? So a lot of these innovations are still stock dependent. I mean, they still have to be able to find a way to do that. And so, I hope she's listening on the line, but MedSaf in Nigeria would be the first to tell you that she's financed through friends and family right now, and the VCs don't understand her. She's a tech company, but she's also like a distributor basically, and they just don't know which category to put her in.
Interesting.
And so they just don't know how to approach her. So she's like, I'm looking for financing. The more financing she can get, the more stocks she can run, the more groups she can work with. And so,
and I think, you see the lack of financing, and folks like the IFC and whatnot are looking for more, as I understand it, this is not my area of expertise in any way, but are looking for more like Series B investments. And as you can see from the size of these companies, they're very small. They're looking to move from self-financing, friends and family financing to like angel investors, maybe VCs. Yeah. So it's like a different category of investment. But one of the constraints for direct-to-consumer companies is that you need to go out and generate a consumer-facing brand, which takes a lot of money to do marketing. Which these companies do not have. And so you see then, I would say that's a constraint to the direct-to-consumer companies, is the inability to do marketing, which then pushes them in some senses to say, okay, well, I'm going to sell to insurers, to private insurers, who that's a longer sales cycle, but I make one sale and I can cover all their beneficiaries. Which is great, but the size of the private insurance market, though that's growing in places like Kenya, and it's growing more rapidly than I had understood. It's not clear to me. Anyway, it's not clear to me that it's large enough in all contexts to provide them the scale they need to get to that next level.
And do you feel like the business case? We were talking before we came in here about could these like micro deals be packaged in a portfolio if there's the business case? I mean, you mentioned the huge markups, but there are other things that we could talk about besides markups. We could talk about efficiencies. We could talk about function. Could we make the case to the public sector even? Can we contrast the performance of some of these things to the public sector supply chain? I mean, do you have a sense that there's still this kind of economic business case to be made before we could even get an angel investor into this business? You could think about it.
I don't know if I'm going to answer this directly, but I just want to make sure that everyone comes away clearly with this message, which I think is related, which is that those companies that we found, you referenced Numi, but Shelf Life is up there. They are finding ways to be profitable, and they are finding a way to, like we said, that there is actually a need, there's a market for providing this service to make that job of that retail pharmacist easier, better, higher quality, and that those pharmacies are willing to pay for it or finance it in various different ways. And then finding out how you finance that and figuring out how to do that at that per shop level is the secret sauce. That's what we can't, that's what you need to go and learn from them. And I think that that's hugely underestimated, is the power and the value of that to transform this market, to offer that real service. So I think that's profitable, and I think that actually has lessons and can be applied somehow in the public sector, that there is value in orienting your service and having this sort of excruciating focus on delivering a service to those groups that are actually providing these drugs, and that can unleash the power of that whole supply chain. So I don't know how else to say it, but
I think that's exactly right. And I think, will the economics of these businesses change as they scale? Absolutely. And I don't understand. They're solving very complex problems with new solutions that we spent a lot of time trying to understand, but we can't see into the details of it. So I expect that the economics of the business will change as they grow. But I would say it's interesting enough to some of the largest private insurers in Kenya that deals are being, done, and perhaps someone on the phone can give us an update, but deals are being brokered now, and the NHIF has approached several of these companies to discuss. Now, there's a lot of risk.
NHIF is Nigeria's.
Kenya's.
The health
Okay.
insurance.
Kenya's public insurer. And so, but one of the challenges with these small companies is that interfacing with a public insurer is quite risky. The ability of some government agencies to write and execute on contracts is in a way that, in a regular sort of efficient manner, it can be challenged. And so for a startup to engage in a relationship like that with a large customer, is very difficult. So most of the companies we talk to, they say like the NHIF has approached us. We're like, oh, that's great. That's a huge pool of patients. They're like, we can't really, it's risky for us to think about them as a big customer at the stage we're at. We need to wait and mature and develop a more robust customer base before we can engage at that level.
Now let me ask you a political question that you can not answer, and then we can ask the audience to opine on. But if you're a global health funder of commodities, and you're running, you know the arrangements that exist now. I mean, should they be purchasing some of these things directly? What implications would that have? What are your thoughts on that?
Yeah. I think that there's a real opportunity to test some of these, to understand what are the benefits to visibility that these provide, and what are the cost savings for our products and for our target consumers. So I think it's a really exciting opportunity to test and gather those data to get a much better understanding of how this compares to the status quo.
Yeah.
All right. So now Prashant is around. So maybe we're going to invite Prashant Yadav, who's a very well-known supply chain guru, really. He's well, for me, he's the one who brought me the world of supply chain, honestly. I've learned so much from him. So Prashant, do you want to make a comment on this work and maybe pose some questions for us to discuss?
Yeah, so I think first of all, it's extremely exciting to see how the distribution and wholesaling market has changed in the last decade. I think we used to work with an assumption that the only way you can get health products to end patients in the private sector is wholesalers taking huge markups and selling products for whose quality we didn't know. And seeing this new wave of business models and technology makes it exciting. It also helps us solve this problem, which I think many of us have dealt with, that retail is very fragmented. And if we want to work with the retail sector for those patients who do out-of-pocket purchasing, we don't have a clear model because of the extreme fragmentation. So these newer models are providing us an opportunity to work above the retail sector, whether it's wholesale distribution, and still achieve some of the social outcomes we see from the out-of-pocket market. And as it gradually starts to shift from out-of-pocket to some kind of pool payment, then it also enables us to be better prepared for that future scenario. So I think one of the key questions for us is similar to what Mara was mentioning just now. Predominantly urban, or the assumption and the biases most people have is, oh, this will only work for urban geographies. This will only work for large cities and higher SES. So how do we make sure that the business models and the cost economics indeed work for the SES we care about, and indeed works in rural settings? That shouldn't be a filter we say those are the only models worth looking at, but at least knowing that upfront, which ones will apply where, will give us a more segmented answer. And the second question, which I think is has been an important question in how to use private capital or how to use public and philanthropic capital for ventures like this, is we worry about development capital taking away some of the discipline, the frugality in how some of these models have worked their way around despite the constraints. And so what should be the stage at which we should say, yes, now this is ready for a larger scale infusion of development capital? And those are questions I think we're still trying to find answers to. Over. Thank you.
Thank you, Prashant. I think that's, do you want to reflect on those questions at all before we go to the audience?
I don't have an answer, but in looking for an answer towards that second question you posed, Prashant, it might be interesting to go back and look at the stories of M-Pedigree, Sproxel, and PharmaSecure, which did get small grants in the beginning from a variety of sources and now have gone on to generate the majority of their revenues from consumers, big pharma companies, and industry. So that might be an interesting sort of case study to look at.
Okay, well maybe now are there any of the companies that you interviewed online that would like to make a comment? Jesse, do you have any sense on that? Okay. We'll tweet at you, Jessica. Jessica is the CEO of Maisha Meds based in Kenya. So let's go here to the audience for comments, questions, thoughts. Is there any? Go ahead in the back.
Sure. David, nice to meet you.
Where are you from?
So I'm a chief of party of 2 programs that fund social innovations and technologies, a few of these businesses.
Great.
There are more that are grant funded than you know. Almost all of them, in fact, in some way. I have a question. As you go further upstream, I'm interested to know what the split on proprietary versus open source technologies are, and whether your insights reflected that at all, because I think we have a convergence of 2 issues. One is the potential for scale with development funders wanting to look for open source solutions that being viewed as a pathway to scale as opposed to commercial exploitation as a pathway to scale.
Very hard question. Very difficult for donors too, I would imagine.
Yeah.
You have thoughts on that?
We didn't explore that. We didn't explore the ownership of the software.
Yeah.
I mean, I'm guessing that this would be a huge profit source for a company, and they wouldn't want to necessarily make it available to everyone, which is a little bit the IQVIA dilemma as well. And I must say, we're running this procurement working group, and there's obviously a huge demand from public payers and procurers for this kind of information. And is it the case that they should be purchasing it? And many donors don't necessarily want to purchase the data, but maybe donors should see this as, okay, well, we want to create this ecosystem, and this data has value. Perhaps it is, and there are also a lot of confidentiality concerns, I think, with the generation of this data and the use of the data. So, I mean, maybe we should think about, making it clear that this data needs to be purchased. I don't know. Do you have thoughts?
Yeah, the only thing that I would add is, actually, as part of the analysis that we didn't present here today, we did ask the companies as well as thought leaders about global public goods in certain areas. Is there a space that might help the entire market move forward? And we asked in various areas in terms of logistics, quality assurance and whatnot. And one area was actually in terms of inventory management, so systems that might help everybody in terms of data analytics. And what we did find from the companies is that was not an area they were interested in having a global public good, because for them, proprietary or no, that way in which they do that inventory management and interface with their providers is what fuels that group purchasing, their financing, allows them to do all of these other bits of value-added service, so that base and that relationship with the provider and by association the client was key, and definitely something that they would view as proprietary. They weren't going to share that with anyone else. And I recognize it's not totally answering your question, but that was what we found across these companies. So.
Yeah. But David, maybe you should also be on the panel. I mean, can I ask you to reflect a little bit on the profitability and future trajectory of these companies, since you're here and you're working on this?
Well, I would say that the 2 programs I oversee, one's called the Human Development Innovation Fund, the other's the Spring Accelerator. They're DFID, DFAT, Nike Foundation, and USAID funded. So it's complicated. This is difficult. We fund a lot of these different companies. I see two layers of barriers to scale. One is geographic, because a lot of this is sub-Saharan Africa. So going to scale, and Sproxel has a story of Nigeria and trying to go to Kenya and Ghana and Tanzania and other places where they can't replicate the access to the consumer model. I think there are approaches to your question, Cynthia, right? On that magic solution of getting financing to the dispensary or the ADOs. So in Tanzania, for example, the AFTA, the Association for Private Health Facilities in Tanzania, has set up a microfinance institution with USAID and our funding through HDIF, which is directly financing operating capital and inventory capital for inventory purchases for those dispensaries, up to about $2,000, so the right amount of money for them to pay for these types of solutions. So those are out there. They're pretty simple, and what that trade association offers is insights that the bank or other traditional financial institutions don't have. So they say, we know their businesses, we know their flows, their finances, they have trusted relationships with those organizations, so it kind of buys down the risk, and they've been able to raise capital, and in fact kicked our money out 2 years early. They're our most financially successful program we funded. So I think at that dispensary level, there are solutions through trade and industry. This question about proprietary software is going to be a big barrier to scale. So you addressed open data, but not open source. Mm-hmm. So the open source question, if you look at like the technology platforms for community health workers, Dimaji and systems like that, they have to meet some minimum threshold of open source. And the donors and funders have all subscribed to the principles for digital development, which includes an aspiration to open source software. So, but I don't think they've been applied so far to upstream. So I was really getting to that question. Upstream, the manufacturer has a pure profit motive. And so even if they're a generics manufacturer, and whether they're willing to give up some of that in order to get some buy down of their risk through a grant fund, so that's the pathway. The grant fund, which would be through programs like ours or Grand Challenges or something like this, then comes to groups like OPIC. But those groups, I think by the time we get there in the maturity of the system, will also be subscribing to the same principles. And I think it's a bit of a fallacy, to be honest, but it's a barrier to scale. So that's a long way to get to my answer being twofold. The geographic barrier is a barrier to scale, and then the pathway to the capital being through development financing is going to be, I think, running up against kind of where the trends are going in ICT for D.
Okay, others up here?
Just a general question.
We're going to give you a...
Hi,
Please
my
say
name
who
is
you are.
Marcy Cook with PSI. I have a general question around scale. So it's interesting that you went from scale immediately from one country to another. I guess the question I would ask you guys is, there's scale within a geography, so within a country context, and then there's scale taking it outside of a country context. And I think we apply an assumption that scale has to actually move markets, rather than what are we learning around how to deliver in different markets that can be moved and cultivate national entrepreneurship or entrepreneurship at that level, rather than assuming that a solution that works in a Nigeria has to move to a Kenya or has to move to a neighboring market. Just wondering if you talk to any of the businesses about their aspirations, and is it scale within their market, scale within multiple markets, differing opinions?
So the Nigerian companies, the majority of them they're like, I'm just trying to go, I'm trying to go whatever to different states, and so less so the multi-country. It just depends on the context of Kenya. The East African market, it's easy peasy for them, right?
NUMI, has this very specific idea around scaling, in the areas that surround the core of major urban centers that have technology, third-party logistics that can integrate into their back end. So they're actually thinking, cities like that have that kind of logistics infrastructure exist in Asia, exist in Central America, et cetera. So their growth pathway looks a little different. It varies.
And they have that length of forward planning associated with that?
Yeah, they have a very ambitious vision.
Other comments? Yes, Jesse, go ahead.
Great. I have two questions from online. One second. So the first one is from Twitter. Chris Masila asks, how is this driving local innovation in health product distribution? And how does this compete with traditional wholesale and distributors? There appears some duplication in some of the provider-facing models. How can they converge? Some of this technology is ahead of regulation. Great. And then the second question is through the webcast. Let me find it. From Stu Stromel. And he says, great information. You highlight the perspective on how all these companies are seeing opportunity to generate revenue in the digital relationship with the consumers. How do you see this changing the way global donors / public good must start thinking in what, must start thinking in what they fund and how they get access to that data?
Can I take that one first?
Sure.
Is that too much?
Those are both such meaty questions.
Yeah, I know.
I wish those two were here to offer more robust comments, and we'll be able to. But I think in the digital relationship with consumers, I just think there's a real opportunity to start thinking about, in an ethical way, how do we leverage digital relationships with consumers who aren't touched by public financing today? So, if you're financing a lot of services and products through kind of input-based supply-side approaches, poor adolescent girls often don't have the social sanction to go to the locations where they can receive the products that are subsidized through, or the services that are subsidized through those systems. So if they do, which is an open question, but inshallah, more young girls will get access to mobile phones in the coming years. If they do have digital sanctions to digital abilities to access financing information and information on services, is there a way for the global health community to connect with them in an ethical way and give them access to those resources that traditionally have flown through or have flowed through systems that they've been excluded from? And you can think, that applies to adolescents, but it also applies to women. It applies to all different sorts of groups of people. And I actually think some of the most interesting innovation that's happening in this space is in the humanitarian field, led by partners like WFP, who have looked at really interesting ways to use digital relationships to give folks who are refugees or living in humanitarian and conflict settings access to resources. And I think we should start thinking about how do we leverage those kind of technologies for people who aren't living in conflict settings but are traditionally excluded and we've had a really hard time reaching. And Cynthia, you want to build on that?
Well, I was thinking about the other question.
Perfect.
Jessica, could you say that for the question again?
So it's,
sorry.
one question was about the contrast to traditional wholesale and distribution approaches in the private sector. I think there was a question about a lot of these models overlap. Are they competing with each other in the same markets? It's no problem if they are, but interesting to hear about it. Do you have any reflections on that?
Yeah, so the contrast with the traditional wholesalers is that particularly these digital marketplaces and fulfillment in a very unprecedented way create that relationship between the supplier and the provider and allow for them to be able to do some comparison shopping in a way that they haven't been able to otherwise. Like basically in the field, what would happen is that you have your relationship with your supplier and you've negotiated with them once and you're going to get the best price from them and
they offer you credit because they know you.
Yeah, and so you stay with that. But these digital marketplaces allow you to look across a couple of suppliers and compare the price, and they have the ability to lock in that price. So they'll negotiate price with the suppliers on a 3 or 6 month basis. Which is, that predictability, it turns out, is incredibly valuable to these providers. The ability to just know that they can get that X amount of product for that price at that time is what gets them on the platform in the first place and keeps them on the platform. So I think that is the distinction with the traditional.
And in some cases, to add on to that, there's even a credit offering. So the digital marketplace will say, like, okay, if you're on this platform, like, we will offer you credit across all the suppliers who are on our platform, which also unlocks kind of relationships that weren't possible previously because, an individual couldn't run around and negotiate credit relationships with all the potential suppliers for all the different products.
Was there any baseline sense in some of these markets, sort of how much quality assured medicine was going through some of these clinics, so that we could really say, because even if they're not profitable, if you're displacing poor quality medicines, that's actually a huge achievement, until such time as the regulatory agency is able to do the necessary inspections and things like that. I mean, do you have any sense, even like a micro area, what the effect has been?
The founders of the Nigerian companies will tell you that is their value add, is the ability to be able to offer quality assured products in a cost-effective way, and that is. I mean, the numbers range. Their estimates, and I don't know how to verify what they're saying. 50% or 40% are counterfeit, and some of the companies actually felt that needs so strongly. It's actually the motivating force for the founding of a lot of these companies, is that they knew somebody that died or somebody that got a bad prescription. I mean, if you talk to the founders, that's why they got into this. They were like, we're going to get good quality drugs, and we're going to get it obviously at a low cost. But some of them are taking that data that they now have from the relationships, and they are pivoting and finding ways to do quality assurance basically on the go, like empowering pharmacists to be able to do quality assurance before they and then trying to find a sustainable way to do it. They're talking with regulators. I mean, it is this viewpoint into the lack of quality and how the medicines are flowing is inspiring a lot of innovation within these companies.
I would say it's challenging because in a place like Kenya, some of the companies will tell you that the consumer demand for quality assured medications isn't that high. So a lot of companies today are saying, like, the only thing that I can do right now is go to suppliers that are certified by the regulator and I think are trustworthy. And that's my quality assurance. And, it's debatable the extent to which that is a robust enough strategy. But the ability for most of these companies aren't yet at a place where they can do batch testing, of products that are moving through their systems. Because, in a place like Kenya, it's a couple $100s to batch test a set of products, and there's, limited suppliers that can. Kemsa does it in country, but, they're one of the only affordable suppliers, as I understand it. Maybe Jess can correct me if I'm wrong. And there just isn't the demand for that. So the companies that are doing it today are either the ones that really are driving for scale, like they understand at scale their inability to have control over quality will compromise the success of their business, or they have grant funding, or they are very driven by the mission and are trying to find a way to make it work. But I would say it's still hard.
My DAO doesn't have to do that level of quality assurance that they do. I don't think they could still sell, and it would add to their profit, obviously, if they didn't do this incredibly secure. But like that is just part of part of their mission. So there's a lot of potential to learn from it.
Do you feel like there's some need to elevate the problem of poor quality in these markets so that consumers value higher quality more? I mean, because part of it is just that there's no demand for it because no one is really aware that it's a huge issue, and it's like throwing away your money if you spend on poor quality medicines. I'm just wondering, I'm just trying to think of ways that a donor could create the demand without, actually being heavy on the subsidies for an indefinite period of time, if it's the case that we want to displace poor quality product in some of these markets, in the absence, again, of regulatory enforcement.
Yeah, I think that's a really interesting question, which Prashant has posed to us as well. Is there an asset-light way to do quality assurance using data? And I don't know the answer to that, but I think it's a question worth exploring. So how do we use the data in these systems from both providers and consumers and the movement of product to understand where quality breaches might be happening? And I don't know the answer, but I think it's an important question.
Yeah. Okay, back to you. Yep. Can you use the side?
I'm Abdurrahim Malik. I'm the creator of FindMyDrug.ng in Nigeria. Thank you. You were talking about quality control. In Nigeria, there's a system where there's a regulatory body called NAFDAC, and they have this number on every product. So if you're a consumer, you go to a pharmacy and you buy a product, you can actually check the quality of that product live. So the pharmacist or the provider does not really have to do anything, basically, if the consumer really knows what to do. But some products are not NAFDAC registered. Mostly American products, UK products that a lot of Nigerians use. So those create a lot of problems when it comes to quality, which is one of the problems my company, Find My Drug, faces. Like this morning, I had somebody needing selenium, IV selenium injection, and I have no way of verifying that, verifying the quality of that, even if we end up getting that product for the customer. But the question I have is, does anybody here know how what we need to do to get prescription drugs for patients in Nigeria without going through the hassle of going to a doctor and getting registered with a doctor in America, and because Nigerians face a lot of that when they need American products, and a lot of patients actually, lose their lives waiting for products like that. If anyone has a suggestion. Thank you.
It's complicated.
I don't know.
We can't get them in the United States, don't worry. There's just a very complex web of regulation governing access to prescription medicines, and a lot of union politics, let's face it, with health providers in the middle, which I'm sure they have in Nigeria as well. But do you have thoughts on that? Are you talking about access to on-patent prescription kinds of medications? Are you talking about?
Like if a patient needs, if like the patient needing selenium this morning is in Lagos, Nigeria, and she can't find it anywhere in the country. So I got the message from the Find My Drug. She used the app, and I got the message. So I've been trying to see, but here in America, it's a prescription drug. To get it, she has to get a doctor here, get a prescription, go to the pharmacy. Then she has to buy it retail price. So if I'm going to get it for her, I have to actually, let's assume she gets a prescription. I have to actually buy retail, then convert it to Nigeria. Ship it down. The cost is astronomical.
Maybe we should be advocating for CSR windows at CVS pharmacy or something like that.
Exactly.
But those are the kinds of things. And there's huge demand for these kinds of medicines. Of course, in global health, we're concerned with, generics and specific infectious diseases and things like that. But I think actually that is the way to profitability, potentially, for some of these companies to be providing these medicines that are not accessible. And the other part is, when in our procurement work, we're looking at what people are buying now, and it's branded generics. And there's a huge cost savings with quality assured generics that would be purchased internationally. So how can we move that market using some of these kinds of mechanisms? It's worth thinking about further.
Yeah, and I would just say exactly what Amanda said. We found some innovators, when we said the direct-to-consumer models are evolving to serve people who are located all over countries and rural areas seeking hard-to-source, high-cost medications. Like in Kenya, I can introduce you to some people who are dealing with that same problem, and maybe it's interesting for you guys to talk about, how are you solving it?
Yeah. Maybe we should have a little summit on that. Okay, in the second row.
Hi, everyone. I'm April Warren with the U.S. Global Development Lab, and I have a question and a comment. So my question is about, I think it was your first two recommendations. Both of them, I think, included sort of targeted discounts, and I thought maybe you could just elaborate on that a little bit and then tell us whether you kind of vetted some of those ideas with some of the companies you talked to, because I just don't know what that means in terms of private sector implications, and do we mean subsidies from USAID and the Gates Foundation, paying for those audiences or geographies forever. So kind of wondering what you guys were thinking around those recommendations on targeted coupons. And then my comment is agreeing with, I think it was David that, yeah, a number of the companies out there have gotten a lot of development funding in different ways, which has good and bad implications, but just wanted to encourage if there are other companies that are on the phone right now or innovators that our Development Innovation Ventures window is open on a rolling basis. And we look for a lot of those companies that are clustered in that early stage space. So feel free to look up online. The application's open all year.
And it's good that they have the budget to be able to do that. So thanks to you.
Yeah.
So do you want to answer some of that? And also referring back to Prashant's original question, which is that are we, in providing grant monies, crowding out these potential investors that would bring the market discipline that would get the companies to profitability faster? A dilemma, but.
A dilemma. Well, the interesting take on that, I guess, with these targeted discounts is that running them through running some of that subsidy through the client directly, I guess, allows the system, that company, to function normally. Basically, it just increases the purchasing power of that client. So I kind of like the alignment of incentives on that, and that it helps those companies in the right way. But your question was around whether we had explored this with companies, right, and the feasibility of this. So the concept is like if you had any of those clients verifying their EC, if you could follow up with them and offer them a discount or a coupon for an injectable or for an implant, something like this. And so categorically, the companies are not, they're not doing this currently, right? And nobody's offering this to them. I think that there are donors that are interested in this kind of an approach, and they're finding different ways to finance it with adolescents in Kenya. But I think there's real potential around it. I think it's just where does the question, the right target group that you're looking for actually having a reliable digital connection that that needs to catch up for it to operate at scale.
I mean, this is like vouchers 2.0, right? Which were generally, to oversimplify things, I guess, which generally had kind of two problems, as I understand it. Like the administration costs were really high, which meant that transitioning away from donor financing to cover vouchers for governments to purchase was pretty unattractive. So I guess one of the questions we're posing here is, are the administration costs lower? And then can you stop, through a coupon, you're maybe not covering the whole cost of that product. You're just, taking 5, 10, 15% off the cost of that product. And what kind of uptake and continued use, if we're using the example of contraception, do you get from that sort of approach versus, a volume guarantee for a product at the top or a factory price ex-factory price subsidy. So it's I don't know the answer to that. I think, but in a space like contraception, where I think, the financing from the donor community is going to stay. We're probably going to have financing for those kinds of products for the next few years. There's a question to ask around, are there efficient ways to use that financing and leveraging some of these technologies?
Mm-hmm. Yeah. It's an exciting area. Okay, one more, go ahead.
I have 2 people online who'd like to speak, so guest 2 and then guest 6.
Okay, guest 2.
Hello.
Yes, welcome.
Yes, thank you. My name is Adebayo. I'm from Arixol, and we're one of the companies profiled earlier. I just want to sort of address the question by Dr. Idris about selenium. So usually this sort of hard-to-source medicines usually will put you in the sort of gray zone around the regulatory framework, where you can only sell the drugs that have been registered by the local authority. So like in Nigeria, it's the NAFDAC. In Ghana, it's the Ghana FDA. Those are the only sort of items that you're allowed to sell. So usually what the regulators usually advise is the doctors should try to prescribe alternatives, what is available locally. And they also are aware that some of these hard-to-source drugs might not be available locally. And so what happens is that they sort of overlook some of the larger pharmacies when they do the importation of these non-licensed, non-registered drugs. So in Nigeria, Dr. Idris can look at Nemit Pharmacy, can look at any of the Med Plus and Health Pluses. These are like sort of large retail chains. They usually would be importing this sort of gray area drugs without any sort of criminal impact on their business. But if you as an individual were to go ahead and do that importation by yourself, you could get into trouble. So that's sort of addressing that piece of the question he had asked. Then sort of the other question, that's my own comment, sort of addressing his question. The question I had here earlier was, in what ways can we actually pull together all of the various innovators in the healthcare space so that we actually are beginning to work with the sort of international partners, donor agencies that are interested in innovation in healthcare? Because if you look at Africa and the innovation space, the guys in the fintech are doing this so well, right? You're having all these great fintech conferences where Visa, Stripe, all those guys are showing up and supporting the very early stage fintech innovators on the continent. We're not really seeing that for healthcare innovators in Africa, right? And I think that's a very important piece, because obviously there is some part to scalability, but the real challenge is the fact that the healthcare budget, both on the macro and micro level on the continent, is rather small. And really where you can actually make a big difference is where you can get as many people as possible early on to begin to use these innovations. But to get there, there will be times where you're actually burning cash, and you say many of these innovators, without the right type of ecosystem support, most likely will peter out. Yeah. So this is sort of the question that I am asking: in what ways can we really pull together the WHO, the USAID, all the guys who are interested in enabling, and it's not just cash, we're talking about things around mentoring, things around commercial partnerships, like we make a nanoscanner for real-time drug quality assurance, right? We go directly now to the FDAs in Nigeria and Ghana, right? But maybe there's a WHO that's actually interested in piloting this out, right? We can actually have that kind of ecosystem for all of the various innovators on the continent to begin to have these direct strategic pilot projects with the people who are interested in this space. So this is sort of my comment question. Thank you.
Thanks very much.
Thanks.
Let's go to our second speaker. Which was it? Number 6? Someone else online that wanted to make a comment or question? All right, we go back live then. So I thought that last question was interesting, which is around how can we work together more effectively? How can we create a more effective ecosystem? Mm-hmm. You have thoughts on that after your work?
I would just echo, we heard from the innovators very similar things to what were said today, that investors don't really understand the challenges in the market and the types of solutions that are going to succeed. So those of us who have some visibility in that can really advocate to help investors understand, and advocate with governments to help them understand the ways in which these innovations can meet and serve their goals, and the types of engagements these companies can broker or withstand in relation to interfacing with the government.
And then the second point around, it's not just about the cash, it's also about the mentoring and creating a support network for them. They aren't, some are connected, but they aren't as connected as you might expect. Okay. So I think there's a lot that could be done in that respect to support them.
Yeah, and in related work we do for Grand Challenges Canada, which April has advised us on, we spoke with some innovators that they finance that are their larger innovators. There's a lot of discussion around the value in peer-to-peer learning when it's really well facilitated. Just providing people contexts of other entrepreneurs working in adjacent spaces to them that can serve as sounding boards and peer problem solvers is something that's asked for a lot. So I don't know if that resonates with those of you who are here, but those are some of the things we've heard.
And if it makes you feel better, I don't think that think tanks are having a big boom in financing at this time. But keep your eyes open. We obviously support our brother and sister think tanks in sub-Saharan Africa as well. I heard someone on the phone.
Hello, can you guys hear me now?
Yes, perfect, thanks.
Great. Okay, so my name is Dr. Samir. I'm the founder and CEO of Livia app from Kenya. And I want to first commend you guys for doing a fantastic job today. Now, coming on to the issue of authentication of drugs, I would like to echo the comments made by Adebayo from Nigeria, where in Kenya as well, we have a very strong regulatory body that's called the Pharmacy and Poisons Board, PPB in short, which I must say does a pretty good job in ensuring that there are no counterfeits in the market. Well, of course, there might be some counterfeits. I mean, that's the problem that many African countries face. But all in all, in the past couple of years, the pharmacovigilance department has really upped their game, and they walk around with their nano scanners and randomly pick medicines from pharmacies and test them for their quality and source. So as far as authentication is concerned, I don't think in Kenya there would be so much of an issue where you want to actually make sure that this drug that I am buying from the shelf of this particular retail pharmacy can actually be traced right back to the manufacturer and what manufacturer. That would not be an issue at all in Kenya. Other than that, there are a lot of innovations happening in Kenya, I believe all going in the right direction, with the focus being the end user, the customer, which I think is great, because when customers are ensured, when the end users are ensured that they're getting the best quality medication at the best price possible, with the convenience of a touch of a button, and there is someone that they can call in case they need to for guidance, then I think it's the customer that tends to benefit at the end of the day. That's my 2 cents.
Okay, yeah, agreed.
Thanks, Dr. Samir.
Okay, so we have 2 minutes left, so maybe I will turn back to both of you. Do you have any final thoughts, reflections? Where does the work go from here?
To follow on from Dr. Samir's point, I think it's a good closing point, but I think along the way, a lot of people have asked us, like, which of these companies should we be investing in, and like, how do you do it? But I think having looked at all of them, the ones to follow and the ones to look at are those that have a really sort of almost excruciating focus on the customer and really figuring out what their problem is and what they're willing to pay for. And I think that is what is going to drive the sustainability of this. And my point earlier around providing services to these retail pharmacists is you might think that they are trying to make ends meet, but here are these businesses that have found that if you can make things demonstrably easier for them and then higher quality, they'll actually find ways to pay for it, in small increments, but that on scale, done efficiently, gives you a business. And that has a tremendous amount of power in these kind of markets. And so that's sort of the guiding light on these companies.
Yeah, I absolutely agree with that. That's the guiding light, is who has a laser focus on their customer, whether it's the provider or the consumer. And I guess to close, I would just say thank you to folks in the room and to the innovators on the phone and those who weren't able to join us today, who were very generous with their time. Though they may have some small grant financing, they're mostly trying to sell to providers or to consumers, and sitting down to talk with folks from global health takes valuable time. And so I really appreciate them sharing their visions with us. And it's really exciting to learn about all the ways they're working. So thanks to them.
Yeah. Okay, great. So I think we'll end now. Thanks a lot for coming. Thanks to those of you who participated remotely and for your tweets and comments. And thanks to Mara and Cynthia for a great talk.
Thank you.